Good morning, everyone. We'll get started in just a moment. Giving folks a chance to join. Always happy to see the chats working. Good morning, guys. Okay, we can go ahead and get started. Welcome to the Kentucky Harm Reduction and Recovery Community of Practice webinar series presented by Voices of Hope and the University of Kentucky Harm Reduction Hub. My name is Brooke West. I am a person in recovery and the training and education manager at Voices of Hope in Lexington, Kentucky. The goal for this webinar is to bring together a group to engage in training, share best practices, and network around a common interest. And today, the topic of our webinar is the psychology of dysfunctional relationships presented by Dr. Sal Corbin. And we are so grateful that he's here today. He's back on the webinar and sharing his expertise. We will also hear an update from the University of Kentucky Harm Reduction Hub. Real quick, just a couple of housekeeping notes. If you are a peer support specialist interested in continuing education credit for this webinar, you need to complete the survey that we will place in the chat, the link to the survey in the chat toward the end of the session. And we have the chat feature on, which most of you have found. So you can participate during the webinar. Feel free to ask questions and make comments. And so today's update from the Harm Reduction Hub will be presented as a conversation led by Casey Bitchek, a harm reductionist with over a decade of experience working in syringe service programs, advocacy organizations, and community-driven research studies. And she is currently a community research associate at the Harm Reduction Hub. I'll toss it over to you, Casey.
Thank you, Brooke. Hi, everyone. Today, as you heard, we're joined by Adams Sibley. Adams is a public health researcher at the University of North Carolina, Chapel Hill. His work focuses on the unregulated drug supply and supporting practical, real-world harm reduction strategies. He's passionate about reducing stigma and helping people make informed choices about their use. Dr. Sibley is committed to centering the experiences and expertise of people who use drugs in research and practice. So we will get into that conversation in just a moment. But before we do, first of all, I do want to just say the views shared on this webinar are mine and Dr. Sibley's. They do not reflect the views of the University of Kentucky necessarily. And I do want to also acknowledge our funder. Vital Strategies funds the UK Harm Reduction Hub, and we are so grateful for their support. And then just for anyone who is new to this webinar and maybe hasn't heard of the Harm Reduction Hub before, just a quick overview. The Harm Reduction Hub is a community service that brings together a team of researchers, healthcare providers, and harm reductionists with the goal of providing early insights into Kentucky's street drug supply, which we do by analyzing residue in used syringes. We have 10 partner sites that provide us with those used syringes, and those 10 partner sites span 5 counties in Kentucky: Fayette, Jefferson, Jessamine, Perry, and Rowan. And then just to ground us a little bit before our conversation, I have this graph showing the 6-month medetomidine trends from our syringe residue testing. So as you can see, we had about 20%, slightly over 18% medetomidine showed up, or well, slightly, sorry. Medetomidine showed up in slightly over 18% of the syringes we tested in September, and then October, November, December, it fell somewhere between 12 and 15%. We saw a pretty drastic drop in January, and then in February, we saw it rise back up to that 13 or so percent. So just to ground us with where we are with medetomidine in those Kentucky counties. But now I'll stop sharing and get into our conversation with Adams. Thank you so much for joining us, Adams. I'm so excited to have you here today. I wanted to start by asking, so as you just saw, our syringe residue testing in Kentucky has identified medetomidine in our local drug supply. From your perspective, what's important for people who use drugs and frontline harm reduction workers to know about medetomidine? What would you include in harm reduction research related to medetomidine?
Yeah, sure. And thanks for sharing that data. I come from a lab in North Carolina that does drug checking as well. And so we have samples from all over the nation. Um, and we don't have a lot of partners in Kentucky, so I wanted to pull some Kentucky data, and luckily y'all already have it. But what I did do is pull data from the states surrounding Kentucky, and the numbers look very similar. In the last year or so, we're seeing about 17% of dope samples um, containing medetomidine. So, your question being, what do people need to know about medetomidine?
Yeah, what do people need to know? What would you include, or like what would you, yeah, what harm reduction education would you give people or recommend people give about metatomidine if they're working with people who are using drugs?
Sure. I guess first off, and I'm sure most everyone will be familiar with this, that medetomidine and this is nationwide, medetomidine is kind of the next xylazine, right? So we had xylazine show up in the fentanyl supply, in the last 5 to 7 years. And our thought is that as the government, both state and federal governments, have started to crack down on xylazine, there's legislation now to schedule xylazine. Some states have already scheduled xylazine, that's pushing um, drug manufacturers, cartels, distributors to switch to a new adulterant that acts like xylazine. And medetomidine is in the same class of substances. We call those substances alpha 2 agonists. The most common drug in that class that people have probably heard of is clonidine. And so all of these drugs in this class, they uh, they are used as sedatives. They are used as blood pressure medications. A lot of those effects that do see in opioids of lowering heart rate, blood pressure, causing sedation, we also see in these alpha 2 agonists like xylazine, like medetomidine, which is why we think probably they're showing up in the supply, is that they are, even if they're not adding to the, euphoric or pain relieving effects, they are adding to that sedation that we expect from opioids. Um, we know how awful xylazine continues to be. We're hopeful that it's on its way out. Um, Medetomidine is different in a few ways. Um, First, it is much more potent than xylazine, so that's a bad thing. The good news is we don't think that medetomidine causes the kinds of skin and soft tissue damage that xylazine did. And I'm sure you're familiar with this, and the extent to which that kind of skin and soft tissue damage can lead to infections and in severe cases amputation. And when I talk to folks who use drugs, that scares the living hell out of a lot of people. Um, So there's not that concern. There are other concerns. I think the primary one, what we've learned from Pennsylvania, which tends to be the place where these things show up first, is that medetomidine is associated with its own unique withdrawal symptoms. So in addition, on top of fentanyl withdrawal or opioid withdrawal, and this withdrawal symptoms are so severe that people are ending up in the ICU. So they're being intubated, they're ending up in the hospital for, upwards of a week or two. And these withdrawal symptoms can be life-threatening. So that's the major concern. Um, a secondary concern, which is something that I found in my research, is that medetomidine may cause hallucinations or delirium or whatever it is. Um, and to the question of well, how do we know if medetomidine is here minus good drug checking data, which thankfully y'all have in Kentucky? Um, But, when I do a lot of qualitative research, when I was talking to folks in Pittsburgh last year, a couple of people mentioned what they were calling trippy dope. And I asked about that, and they were describing hallucinations. And so I thought, well, I know medetomidine showed up recently. Let me run the numbers in our drug checking data. And because we collect information from sample donors, like, did you have any sensations? And so it turned out that if you were taking medetomidine, you had 13 times the risk of having hallucinations. So that's scary. And it's also, I think, like, when we think about the COVID pandemic and you're like, do I have COVID or do I have the flu? And, it's not always easy to tell, but CDC or whoever would release guidance, they'd be like, well, if you have COVID, maybe your taste goes away. And so we have these little signals to say, well, I can't check, I can't take that test, but this feels new to me. This feels unique to me. So it's kind of the same thing with medetomidine. If you're experiencing hallucinations, it doesn't guarantee it's medetomidine, but it might be a signal like maybe I should go get this checked out.
Yeah, that makes sense. And thank you so much for that. We did get a question in the chat, which was just what are the withdrawal symptoms of medetomidine? Can you speak to that just a little bit?
Yeah, I tend to think of withdrawal symptoms for any kind of drug as like, what's the opposite effect of what the drug's doing? And so for medetomidine, it's, rapid heart rate, high blood pressure, would be vomiting, nausea, um, those kinds of things. And the rapid heart rate and blood pressure would be the main concerns, for the health of the person going through the withdrawals.
Yeah, thank you. And I do love the shorthand of uh, it'll be the opposite of whatever the impact of the substance is. That is
Right.
true and also very handy to remember. I see a question from Susan in the chat as well, asking if there's a test strip currently made to check for it. There is. And we at the Harm Reduction Hub are putting together a map of programs in Kentucky that stock those test strips. Um, I, that is what I have to say about that. Adams, I don't know if you have anything to add about medetomidine test strips.
Yeah, I mean, so the test strip manufacturers are trying to keep up with the drug market trends, and they're working really quickly. But it's, science takes tinkering around the edges, and so test strips will have varying degrees of accuracy. Um, and that accuracy also depends on how well they're used. So the things I would emphasize is like, make sure you're working with your harm reduction worker, to make sure that you're, diluting the drug correctly and using the right amount or whatever. And then the other thing is because like, we learn about the accuracy constantly, just like, it's always good to have confirmatory testing, bring in a sample and get it checked with the technology.
Absolutely. Thanks. My next question, and if anyone has additional questions, please drop them in the chat. Can't promise we'll get to them. We have about 5 minutes, but you've already kind of spoken to this a bit, but as um, as you've already said, syringe residue testing does provide early signals about changes in the drug supply, but people who use drugs are noticing it first, right? Like those folks you talked to in Pittsburgh. How can programs best combine the syringe residue testing data with the lived experience of people who use drugs to create timely and trusted updates about what's showing up in the drug supply?
Yeah, I mean, so generally for me, my goal as a researcher, when I'm thinking about what questions to ask, the first thing I ask myself is how does answering this question improve the social and physical health of people who use drugs? And if I can't answer that question very easily, then it's not a research question worth asking to me. And so I'm usually myself looking to communities for the questions that need to be asked. And unsurprisingly, folks who use drugs, um, who have the literally embodied experience of what different adulterants will do have the answers a lot earlier than researchers. And we know xylazine has been around for 20 years. It showed up in Puerto Rico 20 years ago. Why are we talking about it now? We know xylazine's been in the unregulated drug supply in the US for the last 8 years. Why are we just not talking about it now that it's on its way out and another adulterant is showing up? So the important thing is that whether it's as researchers, harm reduction workers, we're constantly in conversation with the folks that we serve. Um, again, I wouldn't have known to ask this question about metatomidine if I hadn't talked to some folks who mentioned this new trippy dope. Mm. So, I think for harm reduction workers, for peer supporters, and for whoever, it's important to constantly be in contact with your clients about has anything changed recently? Have you had new experiences, new sensations with your drugs? Can you tell me about that? Um, because the more we can get curious, the more we can, answer those questions. And, especially for harm reduction workers and peer supporters, because as a researcher, when we answer these questions, our audience is usually other academics. And we do our best to communicate back to communities, but we can't do that as well as folks that work directly with people who use drugs. So it's really the responsibility and the honor of folks, in the field, to be communicating these findings. So we hope as researchers to be able to support that effort and, confirm what the community's told us all along.
Yeah, absolutely. Thank you. I completely agree. It's so important to always center the lived experience, the experience of people who are using drugs and leading from that. All right. Thank you so much, Adams. I'm going to share my slides again. We have a card that we have developed on metatomidine. The idea of this card, which is like a postcard size, is to explain what metatomidine is, and then on the back side to detail metatomidine withdrawal and clinical recommendations for clinical providers. The idea behind this card is that folks who use drugs could take it to the hospital with them if they are experiencing metatomidine withdrawal. We just wanted to share that with this audience. If you have any feedback on it, please feel free to drop it in the chat. Adams, if you have any feedback on it, please feel free to speak up.
No, but it's reminded me of one thing I didn't say that's really, really important for folks to know, which is like xylazine, especially trank dope and now medetomidine and adulterated dope. The naloxone acts on those drugs in a different way than it acts on opioids. And when they're in combination, the important thing to know, and I see this on the card, is that when fentanyl is adulterated with these alpha 2s, um, naloxone will successfully revive the person, but not necessarily bring them back to consciousness. And so what we see is that folks administer naloxone, the person doesn't wake up, and so they administer more and more doses, and then we get into, precipitated withdrawals and folks waking up just feeling awful. So the important thing to know is what we really want to emphasize is restoring breathing
Mhm.
rather than necessarily consciousness. So we're looking for, are they breathing more than, 5 or 6 breaths a minute? And if breathing is back, you might want to, hold off on that second dose of naloxone. Because anyone that's woken up from receiving too much naloxone will tell you they'd rather not wake up from that in that way. So thanks for putting that on the card.
Of course, absolutely. And thank you for pulling that out and saying it. It's so important. And yeah, we've been having lots of conversations about the importance of getting people breathing again and rescue breaths and all of that stuff rather than jumping to that second dose of naloxone. So
Yeah.
thank you.
Yeah.
All right, that is our presentation for today. Thank you so much. Amanda did drop the link to Adam's paper on metatonin in the chat. I will drop, it's linked here, but I will also drop the link to our April newsletter, which came out yesterday, which has all of the data that we normally present in this webinar if you're interested in that. And then you can scan the QR code to sign up for the alerts, our alerts and newsletters. And I will also drop the link to do that in the chat for anyone who would prefer to click a link rather than scan a QR code. Thank you so much for joining us, Adams. This was a great conversation. We really appreciate your time and all of your work and research.
Yeah. And let me just close by saying that I know there's a lot of peer sports specialists in the audience, and just want to say that I think y'all are the unsung heroes of harm reduction. So thanks for all you do.
Absolutely. All right. Thank you.
Awesome. Thanks, Casey. Thanks, Adams. Casey, there was a question about how do we get these cards, and I think Amanda said to email UK Harm Reduction Hub. You're muted.
Of course. You can email me. I will drop my email in the chat, or you can email the UK Harm Reduction Hub address, or yeah, just shoot us an email, but I will drop all of the information you need to reach me and sign up for our newsletters and see our data from February that we normally would have presented in this all as soon as I stop talking.
Great. So Casey's putting all the things in the chat. Appreciate it. Yes, and thank you to the Harm Reduction Hub for your important work on keeping us informed. So now I will introduce Dr. Sal Corbin, who is discussing the psychology of dysfunctional relationships. He has worked for 15 years in academia as a psychology professor before transitioning to nonprofit work. He has done workforce development training and program management as a training coordinator for the Behavioral Health System of Baltimore. He is now board chair and facilitator for the DC Peace Team in bystander intervention, community safety, restorative justice, and trauma-informed care. His vision is to help others build and maintain healthy relationships with conflict transformation as the primary focus. He holds degrees, a master's degree in clinical psychology and a Ph.D. in educational psychology. And so glad to have you back, Saul. Thanks for being here.
Thanks for having me again. Let me see if I can share my screen, first of all. That might be helpful. Okay, can you guys see that?
I can see it. It's not in presentation mode yet.
How about that? Is that better?
There it is. Yep.
Okay. All right. Well, first of all, thank you for having me this morning. And I really want to just acknowledge Adams and Casey for just bringing that information to light. But one of the things I would really like to reinforce and amplify that Adam said was, the peer recovery specialists are really the front line of intervention. And, we have academia, we have researchers, we have policymakers, all with really wonderful ideas and great intentions. But that application is only as good as the transfer of that information to that front line, which we know often gets lost in the weeds. Sometimes the best ideas just aren't really reasonable or applicable to the field work that we do. So thank you again just for your role in that, because when a person is looking to recover or heal from their unhealthy choices, it's the people that are in front of them that will make the difference in their lives. My quote for you today is that you cannot clean a river from upstream. You have to go downstream to the source in order to make a difference. And that's why we're calling this the psychology of dysfunctional relationships. As you know, people that use are fraught with broken relationships, often because the substance of choice will act as a substitute or a replacement for those intimate connections. And when I say intimate connections, you know that I'm talking about partners, I'm talking about family, which includes kids sometimes, and sometimes, of course, friends. That's inevitable in that our attempt to repair these broken relationships often will turn to these outside sources. I'm going to give you a crash course on introductory psychological theory that says this is how we get to places like domestic violence or codependency or sabotaging, low self-esteem. These are just some of the outcomes that follow our unhealthy choices. Now, let's just be real. We're talking about this under the umbrella of substance use primarily, but people outside of using have just as many broken relationships as those within it. It's just more salient and pronounced when you are using about what those relationships, the harm that has been caused to those relationships. But don't think that our choices are necessarily any worse than others. If you just look at the state of the world, it's chaos. There's broken relationships everywhere. So I'd like to speak to it first from a general sense and then specifically from substance use and harm reduction. I also want to address what we can do as support specialists, because there are limits, even though you are the front line. And we need to be sensitive to those limits so that we don't cause further damage. Even though I recognize that some, if not most, of the feedback or support that they will receive from you will be the most valuable that they receive from anywhere, right? But there are other places that they will look to for healing, whether that's support groups or professional counseling or pastoring, whatever. There are, different sources for support. Now, having said that, the theories that I'm presenting today are the original schools of thought. I'm not presenting a lot of them. There's like 3 of them I want to just mention as sources for where these unhealthy choices can come from. I'm going to give you a developmental perspective. The developmental perspective says that there are certain issues or tasks that need to be resolved at different stages of life. And if they're left unresolved or resolved in an unhealthy way, it continues that negative pattern and will affect how we show up in our relationships today if left unaddressed. So yes, all the way infancy, all the way to adulthood, they will stay with us if left unaddressed. Okay. But you don't need to say that theory is outdated or not current. I'm not getting into the current models because we just don't have time for that. So if you will indulge me, I'm just going to give you some background information and then let's get into what we can do. One of the most popular theories, psychological theories out there in terms of unhealthy choices that can potentially traumatize us is in infancy and how we attach to our parents. And this particular research was done way back in the 70s. It was done with moms and their infants. And basically, they were observing the interaction of the infant with the mom in what was called strained situation. So it was basically a research room, a clinical room, and then they would ask the parent to leave and observe the child's behavior. And then they would ask the parent to return and then watch the child's reunion with the parent. The good news was back then, I don't know if it's this way now, I assume that it is, that most of us come out secure, that we see our parents as a safe place from which to explore the world. If you ask the parent to leave, the infant in an unfamiliar environment will naturally cry. When the parent returns, it's a loving reunion, and everything's okay. But for some infants, for some children, they are used to being left alone. And these particular infants come out what we call avoidant. They don't seem to need or crave the connection or intimacy that secure children do. So what happens is when this parent leaves the room, the child doesn't fuss as much. There's very little crying. And when they return, they don't seem to have a need or desire to be picked up and reassured. We call those avoidant infants. These are ones that are used to being left alone. And there's actually 4 categories now, but the third one in the original research was is a resistant infant. And these are probably the most insecure of all. They don't like being in a strange environment to begin with. The parent leaves and they throw a tantrum. And not only do they throw a tantrum, when the mom returns to the room, they have what's called a mixed reunion. So the child wants to be picked up, but they're also fussy and mad that the parent would do something like, what the hell were you thinking, leaving me here alone? So yes, they want to be comforted, but it's also has threads of anger and confusion. And this is probably the worst state. So now look, I don't want people thinking, oh, if you're in one category, you're going to be there forever. Remember, I said yes, if left what? Unaddressed. So I can definitely think of times in my life that I've been secure and I've been avoidant and been resistant in different relationships, right? But I'll give you a great example of avoidant behavior. If you've ever tried to get really close to somebody, and the closer you get to them, the further they back away, like they don't like that closeness, that's probably somebody that's avoidant. They're not comfortable with intimacy. If you were ever with somebody that was just a drama king or queen, they were just insecure all the time, needed a lot of reassurance all the time, then they're probably a resistant or very, very insecure person, right? But we can fluctuate depending on life experience through these different categories. Again, it's just a foundation for understanding how we end up in unhealthy or dysfunctional relationships. Because remember, our life experiences, both positive and negative, but today we're talking about the negative ones, will continue to show up later in life, right? So how we show up. Now, just think about it. If you were in a relationship where you really, really cared about the person and then it had a sad ending or your heart was broken, you probably didn't just jump into the next relationship with open arms, ready to go again. You probably a little, reserved and held back a little bit, and you need to build trust. It took a little more time. So that's what we're talking about in terms of these unhealthy choices. What becomes really unfortunate is when the person gets replaced with the substance, right? Okay, this is a famous theory by Erik Erikson. Again, I don't need you to accept the theories. I just need you to hear what they're offering in terms of how we develop. If you look at the very first stage, remember, stage theory, the issue builds on the next stage, right? So how you resolve that first stage will then affect the other one. And if you look at this particular stage theory, look at the terms on the left: trust, autonomy, initiative, competence, identity, intimacy. These are positive terms. If you look at the right side of that equation, mistrust, insecurity, guilt, inferiority, confusion, isolation. This is the pattern that develops. And again, that pattern needs to be arrested at some point. That's what we're talking a lot. You hear now, intergenerational trauma. How do we stop the cycle from continuing? Because we pass these on from our parents to our kids, sometimes unknowingly. But look at the first year of life. Infancy is based on what? Trust. Trust is simply what was your parent in a place where your needs were taken care of? Can I trust the world to meet my needs? And many of us are brought into the world where that's not the case. So we're brought into a world of mistrust. In fact, Erik Erikson back in the day would have told you that during the first year of life, you cannot spoil your kids enough. Spoil the hell out of them. Give them everything because you're giving them a consistent message of what you are taken care of. Now, if you continue that spoiled after that first year, that might lead to some other issues. But that first year of life, you can't spoil them enough. Okay. I also want to kind of just reflect, look at the fifth stage there, identity versus confusion. This is really, really important in terms of psychological development, because if you are confused about your identity, which many of us have been, which is why we look to outside support to help us define that, right? So we get connected to the wrong peer group, or we look for some type of like, let's say, gang membership, or just anything that we can for our identity to feel complete. But if you're confused about who you are, my question to you would be, and this is adolescence, so this is our teen years, when that's our forefront. We get discouraged and defeated if we have a pimple on our face. So how we look and being a part of, and being included, and being popular, or at least having some kind of skill set that people respect, whether that's athletics or the debate team or something, is really, really important to us back then. But if you don't know who you are, then who is that you are then offering the world? Which means you're probably putting something out there that is incomplete, and you're looking for something to help fulfill that. I'll give you the adult version of that you all would be familiar with. It's called codependency, or self-handicapping, or sabotaging. I know we've had some of us probably are some saboteurs here in this audience. I know I was for a time. I was a master saboteur of relationships, when it meant I entered them looking for things to go wrong, because I didn't believe that those kind of connections lasted. Why? Because my model was, I came from a divorced, violent family, watching my parents argue and fight all the time, and ended in a bitter divorce. So my model for relationship is that kind of stuff doesn't last. So I went in looking for it. Now, here's the thing. When you are looking for something to go wrong, what happens? It's what you all are familiar with. It's called the self-fulfilling prophecy, because where you look for evidence, you will find it, even if it's not the right evidence. So we will interpret things so that it validates what our belief system is. And if you look at that sixth stage, intimacy versus isolation, there's a couple more stages after that, but intimacy versus isolation. Look, if you don't know who you are, it compromises your ability to connect intimately with others, right? And this is one of the problems with that. I'm going to come back to codependency. If you have the inability to be connected to others, right? To develop intimate connections with others. This is Maslow's hierarchy of needs. It's been revamped since the original version, which is this one. And the way this pyramid works is that you have to meet the lower level needs to move up to the top of the pyramid, which is self-actualization, being all that you can be, your ultimate level of being. Some folks in recovery have reversed physiological and safety, saying safety is the most important level, even above, eating and drinking and getting rest. But for Maslow, your physiological needs, right? Just survival needs are first, then your need for safety and security. But look at the third level. Belongingness and love. So that means that's that connection that we were talking about in terms of our relationships. So when we don't feel truly loved, we don't feel truly connected, these are your psychological needs. Guess what? We start looking outside for that need fulfillment. Now, not all of those outside looks are negative, right? Some of them could be, exercise or art or poetry or music or financing, or there's lots of outside places. But you all know what we're talking about. We're talking about the places we go that people refer to as vices: gambling, substance use, overeating. You pick the vice, but when we don't feel connected, we try to reach to those outside things to make us feel complete. even materialism, right? Some people define themselves by that need fulfillment. Well, I don't have great relationships, but I'm surrounded by a lot of cool stuff, right? I'm not judging any of it, right? Because I have reached out myself. I have lived experience like you. So I know what it's like to reach out to the wrong places for that connection. But if you look on top of that one, esteem. So what you think about yourself. This was the greatest thing in my own journey, was the compromise of my self-worth. I felt like I didn't deserve anything better. And so you can see how things build on top of one another. Again, if you accept the premise of developmental psychology. Now, let me just go back up. Remember, we talked about identity, right? So what happens when you don't know who you are and then you get into a relationship? This is what's called codependency, when your self-worth, your self-identity becomes defined by your partner. And this can be very, very harmful to you and the other. But what happens is we start compromising our own needs and worth for the other. Now, as you all know, relationships, interpersonal relationships involve two people, not one. And there's a balance. There's a balance of needs, and there's a balance of responsibility and intimacy and decision making. All of those things, should involve two people. It's a dialogue. But some of us get caught up in what's called codependency. First of all relationships are codependent. Some codependency is inevitable and is good, right? It's a good thing. It's a healthy thing. But some of us will then allow our partner to define who we are, right? So everything that they say is what we do. So this is a slide that just kind of gives you some questions that will help frame that. So do you give in to, and this is not for you, this is for anybody, participants, whoever. Do you give in to your partner's demands and apologize rather than stand up for what you want? So whatever they want is the agenda, is the schedule. Do you find yourself absorbed in your partner's life to the exclusion of your own? So it's all about them. Do you feel responsible for your partner's problems or try to control them? That's a gold mine for using relationships, right? You know that folks try to fix their partner. And so depending on the dynamic, that's another qualification. Do you feel that nothing you do is good enough? Are you staying in a bad relationship to avoid being alone, or staying out of fear, guilt, obligation, or just to say you have someone? That was me. I just didn't want to be alone, particularly on major holidays, right? I wanted to have a date. So sometimes I would pick the wrong date, right? Somebody that I knew was really not good for me, but at least I had somebody, right? Okay. So what happens in codependency in terms of arresting or confronting that particular pattern is learning how to be happy alone, right? Because if you don't know how to do that, and I don't mean, look, folks, I don't mean, skipping and dancing into the sunset happiness. I'm talking about, are you content being alone? Can you, I used to be marvel at people that could go to dinner and the movies by themselves, right? Until I acquired that skill myself. But it took practice and strength. It was very uncomfortable. But are you content being alone? Otherwise, what happens is your happiness is defined by the other, right? So again, there should be overlap of roles, balance of responsibility, giving and sharing. But if it's too one-sided, then it's codependent. So, and then some of us just stay in relationships that we know should have ended a long time ago, and we don't know how to leave it. But letting go and knowing how to end a relationship is just as important as knowing how to begin and stay in one. Now, having said that, the question really becomes, well, what can we do, right? I mean, let's go with some beginning thoughts, all right? When you are supporting others, your participants in your various programs, you can have a supportive conversation with them without crossing the clinical boundary. But Here are some beginning thoughts for you, and let's build on them. First of all, you need to ask, is it worth it to preserve this relationship? There are many relationships in our lives that are not worth preserving. Now, that requires honesty with ourselves, and sometimes we need outside help to answer that question. But, different people in your lives have different worth, as it will be the people that you're supporting. And so helping them to gain clarity on the worth of preserving that relationship is a conversation that you could have without getting clinical. And don't worry, I'm going to give you a model here to follow in just a minute. So these are just some beginning questions. Reciprocity. Well, do they both want it? What does that mean? Well, the people that we're trying to repair or reconnect with or heal with, they may not want it. They may not care, right? So is this your agenda? Is it their agenda? And are the other players that are in their world, are they wanting that as well? Healing is maximized, folks, when everybody wants to be at the table. But I know we all have people in our worlds don't want to be at the table, no matter what your intentions are, no matter what kind of apology you think you need to give or deserve, right? If I were to ask the question, how many people in here have ever been hurt in a relationship, everybody's hand would shoot up. But my question would be, how many of you have ever hurt somebody in a relationship? Probably everybody as well. But the question is, whatever you're trying to do to resolve or reconcile with those folks, what if they just don't care anymore? Or what if the incident or the trauma that occurred isn't as important to them? They got to want to be there in order for this to work. That's an unfortunate reality. But the end of the day, the only thing that you have control over is you and how you show up. It's not what you're saying. It's how you're saying it, right? It's not what you're doing, it's how you're showing up. Okay. Humility. Now, this is the toughest one because for those of us that have been hurt, we are usually looking for something, acknowledgement, an apology, some type of compensation, something that from the person that caused the harm. Now, if you're looking to repair and reconnect with somebody, from an unhealthy relationship, that means you got to create a safe space for them to enter to have that conversation. And many of us, quite honestly, are not humble enough to do that. We're so wrapped up in our pain, we're so wrapped up in our misery that all we can see is red when that person enters the room or says something. This is synonymous with what you all call triggers. Right? I was just talking to my next door neighbor yesterday, who's gotten into it with his father-in-law because his father-in-law triggers him. Every time he says something, he just goes red. And so we were exploring some safe options for him. But yeah, I mean, can you enter that place and especially supporting others and create a space to have that conversation, to actively listen? I'm going to talk about that here in just a minute. Accepting and managing expectations, right? Folks, this is a hard one because I'm a fix-it person, right? So when you start talking to me, like I already jump into questions, comments, directions, and stuff like that. But can you manage your expectations about their pace? Harm reduction, one of our foundational things is what? Meeting them where they are. Not directing them to where you want them to be, meeting them where they are and having that conversation, which may not be your intention or your pace. That's a tough one, especially when you feel like you know what will help them, continue to progress or to continue to heal. They may not be ready for that. They may not want to be in that space yet. I'll give you a great personal example. My daughter will always, and she's a grown woman now. She's a licensed clinical social worker, which is amazing because I'm only 39 years old. But here's the thing. That's a joke. She will tell me stuff that's happened a long time, like months after it's happened. She'll tell me the drama that she went through, and I'll be like, "Well, why didn't you call me when you were going through it? Maybe I could have helped out." But what she says is that it takes her a longer time to process that information, and she wants to be clear on it in her head before she shares it with somebody else. I grew a whole level of respect for her boundaries when she said that, because me, I'm impulsive, I'm impatient, I jump right into fixing something, and she's like, nah, it takes me a lot longer to get there. We have to be prepared for that unequal response, no matter how excited we are, no matter how helpful or supportive we are, for where they are in terms of their own process. And yes, you can explore, because of that, how patient they are and how they view forgiveness. Because if you accept the fact that we have all hurt others and we've all been hurt, that means we all have to navigate forgiveness. And I'm not going to force forgiveness on you. But let me tell you what Desmond Tutu said about this is the South African bishop on the Forgiveness Project. He said, when I talk of forgiveness, I mean the belief that you can come out on the other side a better person than the one being consumed by anger and hatred. Remaining in that state locks you in a state of victimhood, making you almost dependent on the perpetrator. And if you can find it in yourself to forgive or reconcile, then you will no longer chained to the perpetrator. You can move on, and you can even help the perpetrator become a better person too. Now, the reason I'm covering this with you is because how you view and approach and navigate forgiveness will show up in how you're supporting others in that same process. My brother, who's been in recovery, he used to come in my classes, and he had the saying that when you're hanging on to all that resentment and anger and betrayal and hatred and all that, that's like you're peeing on yourself because you're the only one that feels it. Right? And you're a bomb waiting to explode, because when you do finally explode, you not only hurt you, but you hurt the others that are around you. Okay. Now, having said all that, because I want to give some space for, some interaction and questions and comments, what can you do? Right? Because you are peer support specialists, right? You are not clinicians, right? Even if you are certified or in counseling or clinical work, that doesn't mean that's necessarily your role. You see the challenge there? And look, I've met many of people, and I'm a clinician, but it's not my role to be their psychologist, right, or their counselor. Now, which means that I shift in terms of how I show up to support them, which is what are they asking for? What kind of support are they asking for? And can I meet that need that's not under some type of diagnosis or treatment plan? And there are things that you can do, but I encourage you just to be careful of that, because as a peer support specialist, you are providing, counseling support, so to speak, right? It's lived experience, so it's probably some of the most valuable feedback that they can receive. But if you cross the line and you're wrong, you could end up doing more damage than good, right? And doctors have to take what's called the Hippocratic Oath, right? Do no harm. So just be careful about how far you go in supporting somebody. That role, whether it's a psychologist or a licensed clinical or psychiatrist, whatever, those are licensed roles specific to certain types of training that really go further into that cleaning up the river from downstream. What's the source of this? Was it unhealthy family relationships? Were you abused or traumatized? Things like that, which, even though you might be sensitive to, may not be the person to address that particular issue. Now, before you support anybody, The most remember what was that first stage in Eric Erickson's theory? What? Trust versus mistrust. Well, here it is again. As a support specialist, do you have rapport with the people that you're supporting? Do you have trust with them? You cannot have a conversation about any kind of mental health issue with someone who you do not have trust. Otherwise, they might disengage. And you know that the folks that we support often come with a history of mistrust, depending on who was the person or persons that supported them before. There's a lot of disappointment in the work that we do. That's why we often say you got to celebrate your wins, because you can't save everybody, or I should say support others in saving themselves. Notice I said that. Support others in saving themselves. And some people just either aren't ready to do it, can't do it, or something else happens before they have a chance to. So we have to be real with the work. But are you providing that safe haven for them to show up consistently with their questions, with their trust, with their ask for your direction, right? Now, one of the things that I do is I enroll them in their own recovery, right? So notice I say here are some questions you can ask that are not clinical, right? You don't have to have the clinical hat on. And now notice I say if coherent. Now that's not to be funny, but sometimes we try to have these conversations with folks when they're under the influence. That's not the time to have that conversation. Let them come back down to baseline, right? Bring them back to whatever their reality is that's under minimal influence, so you can have these kinds of conversations, right? So one, has this happened before? I think everybody's answer to that will probably be yes, but depending on the situation. What's worked for you? Well, when you've had these symptoms, right? In mental health, we say, see the symptoms first, right? I'm sorry, see the person first and the symptoms second, because we live in a world that does the exact opposite, right? So we see the symptoms and we react to that. So, when you've been under this influence, what's worked for you, right? In terms of your own recovery. And then how can we show up to support you? How can I show up to support you? That's my favorite question to ask anybody, anytime, right? What is it that you need? How can you possibly support somebody if you don't know what their needs are? Which means you got to be willing to have that conversation and listen. You got to let them share their story. Otherwise, you're trying to help them in the blind, which, like I said, can do more damage than good. You all know this information already. This is the harm reduction model, right, of client-centered support. So again, look at the person first, not their symptoms. Look at them as temporarily disconnected, that their situation, even if long-term, is temporary, which means that you believe that they can recover and heal. Because if you don't believe that, then you need to have an honest conversation with them. You may not be the best support person for that. Total acceptance, that doesn't mean you're agreeing with their actions. In psychology, we call this unconditional positive regard. That just means you accept them for this is meeting them where they are on their journey based on their experiences, and that's okay. And then you can have a conversation about how to move forward. But if you're judging them, right, or in your mind, no, then you've already set up barriers for support. So empathize. If you have lived experience, then you all know you've been there, right, before, just as I have, which is a whole nother level of sensitivity and understanding. Do you have to have lived experience to help somebody? Absolutely not. But having that chapter in your life surely sensitizes you to how choices are accessible and made. Allowing them to take personal responsibility. Don't fix their problems for them. Allow them to enroll in that conversation so that they can move themselves towards healing. And you're a reference, you're a resource for them, right? You can support that by offering suggestions or whatever, but you let them do the work. When I first got into nonprofit work, a friend of mine said, "Hey, don't be willing to work harder for somebody than they're willing to work for themselves." And I was like, "Ooh, that was pretty good." Like that helped me know where to stop, right? Like if I know somebody's really trying to heal or recover, they can have the shirt off my back if they're really trying. And I understand that process, but somebody who wants you to do the work for them is not going to benefit from that exchange. And use reflection. Don't assume that you got it right by listening to it. Check in with them. This is what I heard you say. And then give that to them so they can validate or invalidate that. I use often what's called restorative inquiry. This is a restorative justice process that just involves two people, because you've probably heard of restorative circles or victim offender dialogues, things like that. This is just a one-on-one conversation. It's just an example, not the example. It's one of the things that I use, but hey, use what works for you based on your strengths and your knowledge set. Okay, so this is where the receiver, that would be you, fully and actively listens to the story of the giver and then proceeds to dig deeper with questions. Listen to understand. So this is one of the things that when I wear my professional hat, I always have to, once I put on my professional hat, I'm on point. As soon as I take it off, I'm terrible with my community. I'm an interrupter and all this kind of thing. Not because I'm a bad person, because I want to help you fix it, right? So I just jump into it. But listening to understand means you're not jumping in there with a lot of questions. You're letting the person fully express themselves, right? And then asking them if there's anything more and reflecting. But remember, we're not counselors, we're amplifiers, that it's okay to feel uncomfortable with this conversation. I don't know why anywhere it's written that all conversations are supposed to be comfortable, especially in recovery or healing. You're visiting the pain, so of course it's going to be uncomfortable. That's okay. Take it in stages if you need to. Make sure you're taking care of yourself in the process. But please identify your strengths and gifts. Not everybody is gifted in the same way. And this doesn't necessarily mean, because you're a really good worker, that makes you a really good support person. No. Some of our gifts are verbal. Some of our gifts are physical presence. Some of our gifts are in the numbers. Some of us are just our resource encyclopedias. Know what your gifts are, your strengths, so that you have that to offer them in their own healing journey. So finally, tips for listening and inquiry. So be present. Remember that your nonverbal communication is very, very important. So try to avoid any frowns or avoiding eye contact or looking at your phone or your watch, right? Respect the space. And the three questions you really want to ask in this inquiry: what happened? What do you need to heal? And what can you do today to move towards that? Or how can I support you to move towards that process? Remember, always acknowledge them. Whenever I'm working with somebody, almost the first thing out of my response is thank you for sharing. I hear you. Hey, I get it. Yeah, I've been there too. Yeah, I'd be upset too. I'm validating where they are before I get into where can we go. That must be really tough. And if I don't know what to say, then I say that up front. Wow, that was, man, I don't even know what to say, but I'm here. I'm not leaving. All right. I'll sit there in silence with it. Look, I had a friend of mine call me, and she lost her brother and her older brother and older sister in the same 24 hours. One to a failed, I think it was a kidney transplant, and the other to cancer in the same 24 hours. And she called me, and I was just like, well, what do you say to that? And so finally what came out of my mouth was, because I thought maybe I just needed to go and, be with her. She was like, no, there's too much family here. It's a mess right now. I said, well, just let me know when and where to show up for you. Like, what do you need? Right? Let me know, and I'm there. But you got to enroll them in their own recovery. You can't assume for them. It's a conversation, and it's got to be safe for them. If you're not establishing that safety, then they're not gonna speak openly and genuinely into it. Okay. I think that's all I want to say for now. Let me come out of there and just see if we have any questions or comments. If you need information from any of the slides, I'm more than happy to provide them. Thank you for tolerating my rant. I'm here to hear your input. If you have other ways of approaching it, and certainly your questions.
Hey, Saul.
Yes.
So we've got plenty of time here. go till 11:30, but I've got a question for you.
Mhm.
Um, so I think knowing you've mentioned like how important it is to know yourself in this work, and when working with others, and also, I mean, de-escalating conflict. It just comes up a lot. You've got to know yourself, know your limitations, know your role. Um, if I'm someone listening to this today and I feel like, let's say they just don't know where to start, where do you suggest someone starts this journey of trying to know themselves and trying to start this work?
Yeah, that's a very good question. So couple of things. One, you have to uh, start to take an inventory of what you think your strengths are. What is it that you have to offer the world? Now, and that can be everything from huge to minimal. But what are your assets? What is it you have to offer? What are your strengths? Now, a good way to start that, if you have no idea where to start that, is to ask, what do people come to you for help or support? Like, meaning, if there's a crisis somewhere, uh, anything. It doesn't matter if it could be a shopping crisis, it could be a driving crisis, it could be a recovery crisis. Like, when do they call you and say, "Hey, Brooke, you come take care of this because you're really good at it"? What are you really good at? Start with that inventory. And then also start with what you're not good at, right? The things that you don't think that you can offer. I'm impatient. So patience is something that I have to like discipline myself to do, right? So that's something that I have to remind myself when I move into that space. I'm impulsive, I'm impatient, which also means that sometimes I can make wrong choices that are costly. So professionally, I have to be very, very sensitive to that. But start with the inventory. Second, I would recommend taking some type of personality test because that will give you a meter for where your different personality styles are amplified or where you need work. And third, get into counseling. I think anybody that's supporting somebody else can benefit from counseling. And counseling doesn't mean something is wrong with you. Counseling means just kind of your question, Brooke. You're looking for clarity on who you are and what you have to offer. If you don't look, the other wonderful thing about knowing who you are and what you have to offer is it also helps you to respond in what you can't provide. That shows up in what we call our boundaries. This is where we fail a lot in this work is we don't know how to establish professional boundaries or sometimes personal boundaries, which are just as important. And boundaries only work. This is you saying, here's what I will do, here's what I can't do, if they are expressed, agreed to, and enforced. Expressed, agreed to, and enforced. It helps define the relationship. You might come to me and say, well, so I need $100. And that allows me to then say what? Well, you know what? I can't provide $100, but I do have a 20. Will that help you in your journey? It allows you to respond with sincerity about what you can provide, and then also possibly a referral for where they can go to get the other. Right. But that's not what we do here. If you come to my house, I don't have any, I don't have a clothing closet, right? Just so you can pick from. But, St. Matthew's down the street, they do. They have a clothing closet. You can go pick as many clothes you. I'm just using that as an example because what happens is it becomes a free for all. People can come in with any issue and need that they want. And it's important for you to define what it is you have to offer. But most importantly, your presence. That you consistently show up in that way, that would be the most valuable thing that you can provide for them because they know you're a source for trust. That's a great question. Thank you, brother.
Thanks, Saul. And you spoke to the boundaries portion, which was another question in the chat, but Kevin Crabtree, our program director, has dropped a doozy in the chat. It says some recovery models like Al-Anon often promote tough love or detachment. How does this fit into attachment theory? Might tough love trigger deeper attachment? Oops, sorry, I skipped. How does this fit into attachment theory? Might tough love trigger deeper attachment trauma, or do you think it is necessary to stop a toxic cycle?
Whoa, boy. Wow. Okay. We need a whole nother session for that question. That was great. So let me tell you how tough love should unfold. Tough love should be a statement of, I love you too much to watch you do that to yourself. Not, you can't do that and I don't accept or tolerate it. Those are different statements. I love you too much to watch you do that to yourself. So this is a space you can't do that. However, here's what happens, because and this is where it gets really confusing. That's why I love this question. Let's say somebody has been drinking excessively and they come home, and your tough love statement to them is, you cannot come in to this space intoxicated. It gets tricky. The actual best thing you can do for that person is actually to let them in and give them another drink. Now, just hear me out, because I know some of you are like, well, the reason for that is because you want them to, first of all, we know that people that are using are some of the most motivated people on the planet. If you deny them in this time and space, doesn't mean they're going to stop looking. They're going to go somewhere and find it anyways. And what you don't want is somebody to continue to endanger themselves and potentially others by going out to find it. So letting them come in, hopefully they'll take it and just pass out, is actually the best option than them getting back in their car or trying to find it somewhere else. Now, I'm only using that as an example of, this is difficult, right? The problem that I see with tough love is that people will announce it and enforce it without an explanation, without a heart to heart. My heart to hearts always precede a tough stance, which is, hey, look, I care about you. I think this is likely to get worse. I'm concerned about your health and safety and that of your family. And when you're ready for help, I'm here. All you got to do is knock on the door. But prior to that, they gotta, you've heard people need to hit rock bottom before they want to climb out. They got to knock on hell's door to realize it's too hot. They don't want to go in. Yeah. You've heard people say in recovery, what they'll seek help when they get sick and tired of what? Being sick and tired. That gets defined by the individual. I've rarely seen tough love as an instrument for immediate change. Maybe long term, through more sufferings, through more trials and tribulations. Because here's the thing, eventually they're going to want to come to a place that's safe for that support, for that direction. But if all you've done is slam the door on them, then you're potentially one of those, you're a closed door, right? And this is a tough thing to negotiate, because we all define love and how we show up for others differently. There's no standardization for that, right? So I've had people in my journey who have left an open door for me forever, no matter what I'm doing. I've had others don't want anything to do with me anymore. And those are choices that they make. But you, at the end of the day, have to protect yourself. It's about self-preservation and your own safety. I know that sounds selfish, but remember, in the process of recovery and healing, the most important thing for you to do is make sure you're right before you're trying to right somebody else. Let me say that again. Make sure you're right before you're trying to right somebody else. Right? So if you're not willing to go through the process of recovery that you're trying to support other people in doing, then that's why peer recovery specialist is such a sacred position, because you have been there. You have done it. But you shouldn't expect somebody else to do something you're not willing to do. So are you in a good space to support? Right? And then you can open up all types of possibility and opportunity for the people that you're supporting. Tough love is, the reason I like talking about tough love is because it brings up enabling, right? Like, if you let the person in, are you enabling them? And harm reduction, you're enabling them to make their own choices, right? And you're supporting that. So that's tough when the person that you're supporting wants to go backwards instead of forwards. But if you truly want personal responsibility to be a reflection of that, that means you're not trying to make the decisions for them. It is tough. But if you can't tolerate that in your vision or you're in space or your space, you're entitled to protect that for your own sanity. Right? Because use can be completely insane with many branches, and we have to know where to turn that off. When you get on the plane, put your mask on first. So everybody can live. It's not, look, if I'm on the plane, I'm going to go for my child first, right? But no, they're saying, no, get your mask on so you can help your child. Everybody lives. Otherwise, nobody might make it. Right? EMTs, make sure your surroundings are safe before you start trying to save lives. These are important. Those are the examples of of tough love that I'm talking about. But it is very situation specific. I hate the answer. It depends. But yeah, it depends. It's a great question, though. And in our own training, in our own recovery, in our own path, we have to become fine-tuned to our sensitivity to how we respond to others. So I never respond from punishment. It's always from love, which is a different statement. Right? Hey, man, I love you too much to watch you do this to yourself. I'm here for you, but you can't come into my house and do that. Is a statement. Where you need to, where we need to go to help you. I'm there. So what we do often is and then you're just another punishing closed door that they've probably experienced so many places. But they'll know when they need to get help. And some of you are saying, yeah, but if they continue on that path, they're going to make it. They're not going to make it. And it's like, yeah, and this is hard, right? If you are truly practicing harm reduction, then you respect that decision, whether they're going backwards or forwards. But you cannot be responsible for their life or their choices. Okay, I'm sorry. I feel like I'm preaching now. Any other questions or comments? It's a great question.
I don't see any other questions in the chat at the moment, but I have been thinking about safety because you've mentioned being safe and safety throughout the talk. And so what does showing up as a safe person look like?
Acceptance, respect, non-judgment, safe haven, the safe haven. Okay. Whenever we have interaction with somebody, we have an agenda. And I'm not saying people's agendas are bad. Sometimes they're good and they're well-intentioned. But where's your agenda coming from? Are you creating a space where people can hear your concerns? They can hear your feedback. They can hear your love, right? Because I've noticed people want to create that space so they can bash them or tell them what they did wrong or demand apology or something. And we might feel that way, but it's like if I said, okay, hey, look, y'all, I'm gonna have a party tonight. I want all y'all to come. And guess what we're going to do? We're going to talk about what's wrong with you, right? With your foulness. Now, okay, not a very open invitation. And I don't know about how y'all heard that, but I would be like, well, you mean talk about what's wrong with me? What's wrong with you? I mean, it's not an open invitation. The humble part that I talked about earlier is a space for both to speak into, not just your story, not just your agenda, but what's going on both sides. You truly want to help somebody, you got to understand all perspectives, not just yours, because you think you know better or you've been there. I was at this conference and there was an indigenous plenary. The guy gets up there and he says, I used to think I was a badass because I could kick ass. That's what he said. He says, but my elders taught me that before you fight, you lead with love first. What's in your heart and mind, right? What are your intentions going into that space? Is it just you wanting to be heard? Because I guarantee you there's another voice probably wants to be heard too with a different story. And are you mature enough to handle that? That's the safe space. It is a conversation. It's a dialogue. It is not a monologue. And if you truly want to help people in recovery, you got to enroll them in that conversation. right? I don't try to bulldoze or talk over somebody, or I know better than you or more, or I'm credentialed. No. What can we do to get you to a different or better space? What can we do to get you to a different or better space? What are you prepared to do? And how can I support you on that? Or that's the safe space. Not well, if you mention that damn alcohol again, this conversation's over. And folks, this is going to be different for different people. It's not an algorithm. It's not just something you plug into an equation. It depends on who's sitting across from you. Some people are just in a closed denial, broken space. That's a different conversation if somebody is ready to receive your help or your feedback. But is it coming from a place of love? Or is it coming from a place where you want to punish, redirect, condemn? You want to be right. You want to be heard. Well, yeah, the reason people are acting up in this world is because probably they feel like they're not being heard. So they either create a scene or they say or do something that gives them the attention that they're trying to get. All right. Meet them where they are, folks. Sit in the dark with them if you have to. All right. Be willing to do that. All right. Because probably in their history, they haven't had folks that are willing to do that. But when they see that you are genuine, they'll continue to come back to you. Because look, help isn't when we decide and define it. Help is when they choose they want it and need it. And where are they going to go when they make that choice? Just like everybody else in this room, there was a point where we decided we needed help. We needed a different space. You know, it was for me when I started drinking. This is many years ago. I started drinking. It had lasted for 3 years, but I was waiting for the liquor store to open up at 6:30 in the morning. Just standing there waiting for the liquor store. I was like, ooh, okay, maybe we went a little too far. Don't want my life to look like this. That's when I was open to people's input and feedback and help and support. But prior to then, get out my face, stay away from me. What about you? Leave me alone. You name it. Anyways, there you go. Great stuff. I appreciate you all tolerating me today. I hope it was helpful. Brooke has my contact information if you need the slides, whatever. If you want to continue this conversation beyond this time and space, just reach out.
Thanks, all. And I just put the link for the continuing education survey in the chat, so folks can grab that. And Saul, you should check the chat. You got some compliments in there. So great to have you
I didn't realize
back.
I could read the chat. Look at that. Wow. Look at you all.
Yes.
Oh, thank you for the love, y'all. I appreciate that. I'm fans of you too. And thank you to Brooke for continuing to invite me back and not knowing what I'm going to say. You all are very much loved. I hope to see you again in soon time and space. That would be great.
And I wish you could have heard me cackle when you talked about having your grown daughter who's an LCSW and that you were just 39. I laughed so hard, and I'm like, ooh, I got to remember to let Saul know how much I laughed. When's your 40th, Saul?
I know, right? Coming up. And the other thing that's funny about my daughter is the things that she does. This is that intergenerational passing on. The things that she does that piss me off. I'm looking in the mirror. So when she disappears and disconnects and doesn't share, where do you think she got that from? But when she does it, I'm like, damn it, who does that? Are you crazy? Say something. Yeah, she got it from me. Anyways.
It's always cute when I do it, but not when other people do it.
Like I have a reason, right, for why I do it, but you shouldn't have one. So
right. And also when you were talking about codependency, there was a small support group forming in the chat. Just want to let you know that really resonated. I got some
and
texts
I've been
too.
there. Look, when you have no backbone in your relationship to express the things that you need for it to be healthy in it, oh man, that's it. Yeah. I used to rehearse how I was going to break up with my girlfriend, and somehow that never happened. I was just still in it. So how did I get here? Why am I still here? So codependency. For those who've experienced, they know exactly what I'm talking about. For those that haven't, they're kind of like, what is that? Like, I don't understand why that would happen. But yeah. Anyways, good stuff. Thank you all so much. Appreciate the love.
Yes, thank you, Saul, and thank you to the UK Harm Reduction Hub, and thank you all for joining us today. I'm going to put the link in the chat just one more time in case it got, it kind of drifts as the compliments come through. Yeah, thanks all for being here. Thanks everybody for joining the webinar today. And everyone go take a personality test, take an inventory of
One,
basically your
one
character
if somebody
defects and
can't find one,
assets.
or yeah. So
But also, there's that you got to look inside, but also reach outside for help. So I'm also glad you plugged
right,
counseling and
because
getting that outside support.
yeah, so no matter what you think about yourself, we all know that there are folks out there that think they're so wonderful, but they're really not, right? But they can't see it. So it's not just how you define yourself, but that you get external validation. If you truly want to know what that is, with your loved ones, your intimate ones, here's the question. What's it like to be in relationship with me? Not, and you don't want the feel-goodsy, sugar-coated answer. You want people that will give you honest feedback, like, oh, hey, you're wonderfully loyal and you're amazing cook and you're wonderfully supportive, but you could be an asshole sometimes. You want that kind of feedback. You want both the good and the bad. What's it like to be in relationship with me? And then you got to stand there and listen to that and accept it, receive it. Yeah. Thank you.
Great. I guess I'll make a couple phone calls later. Thanks again,
Thank
Saul.
you,
Thanks
bro.
everybody for
Appreciate you.
being here. Hope everyone has a great day.